Thank you all to be here. It's a pleasure for me to be here to present my experience on ABUS and how much I appreciate it. I'd like to introduce you something about breast density that is very important for the imaging assessment of the breast, as maybe all you know. I'll explain how ABUS works. I'll present you a study about the coronal view of ABUS that I presented yesterday at the scientific session of breast ultrasound. Maybe some of you was present. If you were present, sorry for the repetition. And I'll show you just 3 pictures for patient examples, and then if you want, we can see some cases together. Before starting, anytime you want, ask me questions. No problem, I'm here for you. I would like to ask you a question. How many of you are ABUS users? Just you and you? Okay. And how many are perform handheld ultrasound for the breast? Okay. Let's start with the game. You should have to find Wally in this amazingly dense beach. That is, as you have to find breast cancer as opacity or distortion of microcalcifications in dense breasts. So here you find Wally, and we know that breast density is crucial for the imaging assessment of the breast. In accord to the ECR classification, we have almost entirely fat breasts. That is the best friend of mammography, but we know that increasing the density, the performances of mammography goes down. As shown in this chart, where you find we know that increasing breast density, the performances of mammography are lower, and the independent risk factor of breast cancer increases. And the ultrasound shows its best performances in these breast densities, or in C and D breast densities. And this is a crucial part of women, and I would like to ask you if you know how many Western women, in your opinion, in their 40s have C or D breast density? You should say 40%. 40%, okay. You're very experienced. And Korean women? More than 70? They are more than 70, 76%, and in some cases 80%. So it is very important for them, ultrasound and automated breast ultrasound. So these women are very common, and this trend demonstrates that breast density is a very hot topic, followed by, take your picture if you want. Okay. Followed by the trend of publication about automated breast ultrasound that is increasing over the years. The history of breast density as independent risk factor for breast cancer starts in the 70s, when Dr. Wolf published 2 papers about it on cancer and AJR. But we waited several years before something really important happened. In 2004, unfortunately, Dr. Nancy Capello, that maybe all you know, was diagnosed with stage 3C breast cancer after many years of negative mammograms. Unfortunately, she died the last year on November. And thanks to her huge efforts, in 2009, Connecticut became the first state to mandate that mammogram reports must include information regarding breast density of the woman. And in the last year, 35 of the United States have breast density notifications laws in effect. But despite this high prevalence and the advocacy of Nancy Capello, there's still no agreement about the best adjunctive diagnostic tool for the assessment of these women. Handheld ultrasound has been proposed as one of them, digital breast tomosynthesis, and ABUS. Among you, how would you suggest for women? For example, do you suggest ABUS for women with enlarged breasts, or you perform tomosynthesis, or do you do nothing?
Well, in my country, we use the ABUS.
In the screening or in the diagnostic setting?
We have I'm from Mexico, so we don't have very good programs,
Mm.
screening programs. So I do a lot of practice, private practice.
Mm.
So that depends on the age of the patient, and it's different.
Okay.
From Europe or the States, they have a very good screening program.
Mm.
But I use the ABUS in younger patients and also in asymptomatic woman who has
So without symptoms?
without symptoms.
If you have symptoms, you perform ultrasound?
The ultrasound.
Yes, I agree with you. Okay, other opinions? Do you agree all? Yes, okay, let's move on. So we need more for these women. And talking about literature, this is a recent meta-analysis published by Dr. Fee and Dr. Tagliafico. They aim to systematically review and meta-analyze the accuracy of digital breast tomosynthesis and versus digital mammography in this kind of women. And they found an increased cancer detection rate significantly higher in the screening and in diagnosis for the breast tomosynthesis. About handheld ultrasound, my friends from Genoa published this important study, the ASTOUN 2, that is the last part of a study with the interim analysis published 2 years before this one. They included, this is a multi-center study of asymptomatic women with negative mammograms. They included 5,300 patients, and the adjunct of digital breast tomosynthesis and ultrasound found 29 incremental breast cancer. 12 of these were seen both by digital breast tomosynthesis and ultrasound, 3 only by tomosynthesis, and 14 were only detected by ultrasound. So the combined use of digital mammography and US generated an additional 4.9 detected cancer per 1,000 women screened, while the digital breast tomosynthesis added 2.8 breast cancer per 1,000 women screened. These are the two main papers published on ABUS in this setting. The first one is a monocentric study. The other one was a multicentric study. It was published in 2014, and I had the pleasure in Chicago to meet Susan Rue and Mark Inchardi, that were among the authors, and we talked about this paper. They found an additional detected breast cancer rate of 2.4 in the first one, with this very low recurrence rate per 1,000 women, while the multi-center study found 1.9 more cancer per 1,000 women screened, with this huge additional recurrence rate, but they told me that the technique was a beta version, so the software was very, very different from the software that we use now. So this could be explained in this way, but the recurrence rate is very important. So we need more, yes, but reducing the recurrence rate is very, very important, and experience is very important in this setting. So, in my opinion, as you said, we agree that the main aim of ABUS is a screening setting. It can be used even in a diagnostic setting, in staging and in the surveillance of breast lesions, for example. For the follow-up of multiple fibromatosis, this is very, very important, considering that using handheld ultrasound is quite tricky to follow up all the fibroadenomas in a human with with a huge number of lesions. So this is quite old slide. Maybe we should update it. But you find the number of units installed in Europe, And the importance of this technique is highlighted, in my opinion, by the presence of that name, Professor Tabar, among the reference customers, a star among the sonologists around Europe and around the world. Talking about how this technique works, this is a young technique, but with 40 years of history, considering that one of the first prototypes were published in the 70s. This was made of 2 tanks. The patient is lying supine in the inner tank, and the other one collects the water outflowing from the intima. It was filled with filtered and ionized and treated with aldehyde water. And the interesting thing is that they normally change it daily. Here you find the main machines available on market. The patient lies supine or prone, depending on the different vendors. These 2 machines are not approved in the US for screening till now. I don't know if we have to update it. Maybe they still are not available for screening setting. From the acquisition, we obtain acquisition that is made from by the sonographer or radiographer, depending on the countries. In Italy, the radiographer performs the exam. I don't know in Mexico, the technicians. In other countries, as the US, the sonographer performs the exam. Generally, the physician shouldn't perform the acquisition. We obtain an almost isotropic voxel that can be reconstructed in all the different planes of the space as the coronal one, in which the breast is displayed from the nipple to the rib cage with slices that are parallel to the chest. And this is the plane that we love most and the first one that we assess during reading the exam. And I'll show you our results about a study focused on the role of this plane, this view, compared to the multiplanar views available to the reader. Here you find the clip. Maybe, Alexandra, you could switch off the light just for a moment. In the center, we have a yellow spot that is a marker for the nipple that is set by the radiographer or the sonographer during the acquisition. And we find the slices that are going from the nipple to the rib cage that starts to appear here in this place. The reference of the nipple is useful for the detection of the lesions, considering that we have then automatic informations about the lesions, about the clock and the distance from the nipple and from the skin. This is the native plane in which the images are acquired, with the probe moving from the feet to the head of the patients. And this is the image that we are more familiar with, considering if we are ultrasound users. The coronal plane is quite different, and you can't obtain it with the 2D ultrasound. This is more similar to the normal handheld ultrasound, normal. This is the study that I presented yesterday at the breast ultrasound session here in Vienna, and we're going to publish this study on the journal of the Asian Federation of Ultrasound in Medicine. The purpose of our study was to evaluate the value of ABUS as a diagnostic tool in women with dense breasts, focusing on the potential assessment of the coronal view alone, compared to the multiplanar views in terms of reading times, diagnostic performance, and inter-observer agreement. From August to October 2017, all the patients that referred to our institute for handheld ultrasound for post-mammography preoperative or follow-up of no benign lesions with the breast density C or D were invited to perform an additional ABUS exam. It was offered to the patient as an optional choice, was not part of the daily clinical practice. And those that accepted the invitation were acquired with the machine. And 2 different reading sessions were performed after. In the first one, the reader could only assess the coronal view alone. and the second one at least 1 month. After the first, the reader could assess all the multiplanar views available. 3 different readers performed the reading session, from 5 to 25 years of experience in breast radiology, and they were blinded for clinical and radiological data of the patients. We obtained results in terms of reading times, comparing the first and the second session, diagnostic performance of the coronal plane and the multiplanar views, considering histology as reference standard when available, and when not available for benign lesions, at least 2 years of negative follow-ups were considered as the reference standard. We tested the inter-observer agreement between the most and least experienced reader in the assessment of breast lesions in the coronal view. From 256 invited patients, we enrolled 188 patients, including 60 patients with breast lesions and 128 healthy subjects with negative ultrasound examination and clinical examination, with 7 cases of DCIS, 16 cases of IDC, 2 LCIS, 20 fibroadenomas, as 15 simple cysts. In terms of reading times, the first reading session found a mean reading time of 83 seconds, that is very quick for the first reader, 84 for the second, and 76 seconds for reading the exam, the entire exam, and considering both the breasts in less than 2 minutes, without significantly statistical difference between them. The second reading session, in which the reader could assess all the multiplanar views, was associated with the higher reading times, even lower than 3 minutes. So it's very quick as, yes.
Yeah, I think it's very interesting, and they're quite fast.
Yes.
If you look at the literature, how is it possible that they're so fast?
Looking in literature, the mean reading time ranges from 3 to 15. Consider that during this session, the reading session was only for the study. It was not a clinical setting. So this is a bias of the study, I think. But the assessment was complete. We have to consider that these readers are experts. They perform breast ultrasound, and they are all sonologists that do only breast imaging during their clinical daily practice.
Yeah. And did you make a separate analysis for the negative cases versus the positive cases?
Yes, in the paper we did that. And the difference is not statistically significant. They're quite the same.
And that time is for the 6 views? I mean, it's...
Yes, 6 or more.
6 or more.
Yes, and only the reading, not writing the report, but the report, it depends on how fast you are writing. If you use the automatic report from the workstation, or if you use another software, so this is variable, depending on your experience and your daily clinical practice. Thank you for your question. Here you find all the results about diagnostic performance. This is a very dense table. Highlighted you find the most significant one, in my opinion, that are a higher specificity of the coronal view compared to the multiplanar views. And this is quite interesting, considering that its potential role in a screening setting, where higher specificity is our aim for a screening tool, while the sensitivity was lower for the coronal view alone. Using Cohen's kappa statistics, we tested the agreement between the most and least experienced rater, and it was fair for echogeneity, shape, and type of margins, and moderate for the Byrat assessment using the weighted Cohen's kappa statistics. Using blunt alto analysis, we found significant agreement for the assessment of the maximum diameter of the lesions on the coronal view alone. The conclusions of that study was that the reading times were significantly lower comparing the coronal and the multiplanar views assessment, and we can say that they've been very quick. The coronal view had higher specificity and lower sensitivity than multiplanar views with similar accuracy, and inter-observer agreement was fair to moderate and significant for the blunt Altman analysis. In our opinion, the assessment of the coronal view alone can be considered as a brief preliminary approach, and in case of the detection of a potential lesion, the reader can analyze all the different planes to confirm or not it, and the complete assessment of all the available planes is still recommended. If you have some questions, or we can see 3 pictures, and if you want, we can watch some cases at workstation, or we can discuss. This is one of the available layouts for the reading of the exam. This is the one we use, in which we have the coronal plane higher and bigger, and on the top of the picture, and the native transverse view on the bottom of the screen. This is a normal case. This is a cyst. You could, Alexandra, switch off, please. Just. Okay. Here we have the image that we are familiar to. If we perform handheld ultrasound on the coronal plane, we see a black hole. While this is an IDC, and this is very important for the coronal plane, considering that we can see a phenomenon called the retraction phenomenon that is quite similar to the distortion that we can see on breast mammogram or digital breast tomosynthesis, and we can't assess using handheld ultrasound, two-dimensional, and the transverse view alone. This is a unique feature of the coronal plane, and this is one of the reasons why we like so much this feature. That I know that this is the feature that Tabar uses when reading an exam. Thank you very much for your attention, and if you want to, you can ask as questions as you want. And this is my son, 1 year old. Thank you.